Sir, we can start the session.
Hello, good morning, everyone. On behalf of the Indian Academy of Neurology, welcome you all to this edition of our webinars. As you know, we have started these webinars in this year, and this is the third one we are going to have. In every webinar, we used to have a lecture from senior experts who usually give their expertise and also helped the junior faculty to learn something from them. And along with that, we also have one important case presentation by a resident or a junior faculty mentored by one of the senior faculties. So today we are going to have a lecture by Dr. Urvashi Shah. She is a senior neuropsychologist in this country. She is known in the field of neurology. To begin, to introduce her, it is my privilege to introduce Dr. Urvashi Shah because we have been working together for last more than 1 decade. She is the first neuropsychologist who introduced the field of neuropsychology in this country. She started a clinic in the neurorehabilitation clinic in Mumbai in 1990s in Sion Hospital. She is also the research consultant in the NIH Mount Sinai Indo-US study on cognition in elderly. She has been awarded with several prestigious fellowships, particularly to mention few of them. One is the Matthew Fellowship by International Neuropsychological Society. She also received the Mayor's Achievement Award by Mumbai Municipal Corporation for her pioneering work in the field of neuropsychology. She is also members of several prestigious committees, particularly the International League Against Epilepsy, the Neuropsychological Task Force. She is also the chair of the International Neuropsychological Society, INS Epilepsy, SIG, and she has been associated with several other committees as well. What is more important to the cognitive neurologist is that she was the expert in the core group of who developed this ICMR neurocognitive toolbox in this country, which is a pioneering work in the field of cognitive neurology. She delivered several orations, particularly to mention few of them, the Bajoria oration in the Indian Epilepsy Association. She also delivered Dear Parmeswaran lecture, the Indian Epilepsy Association Kochi chapter, and delivered keynote lectures at International Neuropsychological Society and British Neuropsychological Society annual meetings. She has several research publications, including the articles, book chapters, and delivered 100 national and international presentations in different conferences. So I invite Dr. Urvashi Shah to present a lecture. She will be talking on neuropsychological assessment for clinicians. I request Dr. Shah to start her presentation.
Thank you very much, Dr. Tan, for this wonderful introduction. As you said, that the most important part in the introduction was being associated with your entire group, being the expert on the ICMR battery. I think that was a huge achievement for me in my whole career. And I'll talk a little about the ICMR battery and what a big landmark achievement it is for us in India to now finally have that battery. But today, first of all, let me thank the cognitive subsection and of the Indian Academy of Neurology for giving me this wonderful opportunity to speak on a subject that's very close to my heart. So thank you very much for that. As all of you know, that in order to diagnose dementia, besides the presentation of the subjective complaints from the patients and the caregivers, a very important another criteria that has come up now is to be able to document the cognitive impairment on an objective cognitive testing. So now we clearly know that we need to do this. But what is the problem? The problem is that we are finding that when you talk about a formal diagnosis of dementia in the clinic, and actually when the presentation of symptoms begin in the home, there is a gap. And we are all realizing that from the studies that we do. And this is a fairly big gap, sometimes ranging even up to 4 years. And many studies have suggested that the reason for this gap is due to two major factors. One of the factors that has been suggested is that the caregiver perceptions, that the caregivers who notice the changes, or even the patient themselves who notice the changes, attribute it to normal aging. So in dementia, this is a particular problem where everybody says, oh, I'm forgetting, or this is happening to me, it's because I'm growing old. And the second thing is also, there is some stigma, of course, attached to the diagnosis of dementia. So sometimes we find that the children, even when they realize that the parent is making a lot of cognitive lapses, they're not willing to come out and talk about it because of this respect for elders that we have in our culture. The second major factor that we've found in many of the studies is the clinician's reluctance to put the label. There's a hesitancy to put the label in the early stages because the same thought that is this part of normal aging? And there is a limited knowledge of how to diagnose these early stages or the early complaints when people come up with that. And also there's a lack of knowledge of about how to use the cognitive screening tools in the early stages to be able to reach the diagnosis. So today, for the purpose of this presentation, I'm going to walk you through the nuances of cognitive screening tools, which you specifically need to understand when you work in your clinics. But also, we're going to focus mainly on the Indian scenario, what is relevant to us in our clinics. So we'll do this through a case that we'll be discussing through the presentation. So let's look at this lady, Mrs. B, who came into the clinic. So Mrs. B is 76-year-old. She's a widow. She lives by herself. She's fairly independent, doing things all on her own. She's a retired college professor. And only recently, she started feeling that there were some memory problems. And more than her feeling, she said to me that, the children had insisted that she come in for the evaluation because they feel that she's become repetitive. She keeps asking the same question over and over again to them. And also, she said, that recently when I went shopping, I found that quite a few of the items I forgot to buy. And then I realized that I'd actually made a list and it was in my purse, but I forgot that I had the list in my purse. Now, the children said, we had been noticing some lapses, but, we thought, okay, normal aging, this happens. But what stood out for them was the fact that recently when she invited her son and daughter-in-law and the children home for dinner, she forgot about it. So when they arrived to her home for the dinner, she did not even remember that she had called them. Now, this stood out for the family as something very striking and odd. And they felt that now we need to think about what is happening to her. So the first question that comes to the mind as a clinician is that this deterioration, these very subtle lapses, infrequent still, not so common, which the family is describing to us, is this part of still normal aging or has this gone beyond normal aging? Now, in order to be able to decide that, obviously, now we can't just go from our subjective feeling. We do need the cognitive tests. We all recognize that there is a prodrome, there is a preclinical phase before you go into mild cognitive impairment. And in the preclinical phases, the individual may notice that I'm changing, I'm growing old, I'm not doing things as well as before. But still, nobody outside of the individual may notice, and the doctor suddenly doesn't know, and nothing is happening over here. It's a silent phase. It's when you enter that mild cognitive impairment phase that the family and the others begin to notice, and one or more cognitive domains starts getting impaired quite significantly, and then finally there's a decline into the dementia phase. Now, this one or more cognitive domain getting impaired requires that you have standardized testing. And most importantly, and this is something that I'll keep repeating through the presentation, appropriate norms. Norms because you are deciding whether this is normal aging or it's gone beyond that. So obviously you have to compare the person's performance on certain good tests to see that it's different from a person who's that age and education. So in the ideal world, as a clinician, if you had to select one of these tests, you would look at the following things to make sure that you're doing a good examination. You would want to see that there is validity of the test. It's a good, reliable test. Very important that when you're looking at the cutoff score, it has a high sensitivity and specificity. Otherwise, you're going to be in trouble, as we see later on in terms of your diagnosis. It should be easy for you as a clinician to administer. You're not like a neuropsychologist with the training going to sit and do very detailed evaluations. But it has to be comprehensive. You have to be able to look at all the domains because you have to do differentials, because you have to also see what type of dementia it is. And most important, you have to have very good normative data. What are the challenges we are facing today in India when we are doing these assessments? We have to have good adaptations of the test. Very often in the past, as I was telling my colleagues here, that I've been in practice for 25 years now. In the past, we did not have good tests which were adapted. We were picking up tests from the Western populations which were not adapted. And that's absolutely incorrect. We have to have adaptations that suit our culture, that are culture specific. We have to have good translations, and we must have our own normative data. Now, we have time constraints for a clinician like you. So you are going to go towards more using the screening test rather than the test batteries, which you tend to outsource to neuropsychologists to do. But you also have to be aware as clinicians that there are a number of patient barriers when you do these testing, particularly because you are testing elders. With the elderly population, there is the problem of test wiseness, which we call the test-taking sophistication. A number of your clients will come in feeling very diffident and anxious because they do not like the idea that they are being tested. They keep telling you, am I back in school? Am I back in college? Why are we doing these tests? And they don't like the idea. They don't have the insight. Many of them will come and tell you there's nothing wrong with me. It's my children, it's my wife, it's my husband who's telling me that you have to do this test, but nothing is really wrong with me. As a part of normal aging, don't we all forget? So this lack of insight, this lack of sophistication will be barriers for motivation to do the test properly, and they may not cooperate. There will be hearing or vision loss. So it's not uncommon that they will forget to bring their hearing aid or not their reading spectacles, and then you're in trouble when you're doing the testing. So a very typical thing for me is to send a WhatsApp message, even on the morning of the testing, saying, please carry your reading spectacles, please carry your hearing aid if you have it. Then there are the language barriers. You cannot, with the elderly, sit and say that I'm going to do all this testing in English in India. You have to be able to do it in the language that they are comfortable with. So these are significant barriers, and you have to overcome these to be able to do a good assessment. You have to, as I said, coming to each of the points, have good adaptations. We are extremely fortunate, and I'll keep saying this, with the ICMR battery coming up, and with Dr. Aladi leading a group of large number of neurologists and neuropsychologists across the country, that we now have a number of adaptations. As you can see that the figures in the naming test, now we have the illiterate battery also, where we now have colored drawings, that they have to be adapted and changed for us to get the right results. The norms are extremely important. Normative data, I must emphasize to you, particularly when you're doing cognitive testing for the high education group and the low education group. These two age groups at the end of the spectrum are very, very important because education effects are very strong in cognitive testing. And also you have to be mindful about when you're looking at groups of people who are in the old age group, because we know as a part of normal aging, there is a precipitous decline in your cognitive function once you cross 80. So your normative data is going to be different once you're in a higher age group. So what happens with the education effect? Just look at these norms which came up from Dr. Mathuranath in 2007 with the original ACE. If you look at it very clearly, that if you did not have these education norms, many of you tend to use one cutoff score for a screening tool. You'll say for the ACE, 82, 83 is my total score cutoff, and you only look at that. That is absolutely wrong, because you will realize that even for the total cutoff, you will see that there is a variation. So if you have someone from a lower literacy or a lower age group, and you're going to use that cutoff of 82 and 83 and 84, you are going to diagnose someone who does not have a dementia as being demented. So please watch out for your low literacy, low education group, because you're going to misclassify them as having dementia when they don't have it. And also for the low literacy group, look at the subtests. So visual spatial, where drawing is involved. You're going to do clock drawing. You're going to do a copy of a figure. Just look at this floor effect on the test. The scores in the normal population are so low that a person getting 0 or 1 is in a normal range when they're of the low literacy group. So sometimes you may want to avoid some of these tests which have a floor effect when you're looking at low education. Similarly, when you look at very high education people, or the very intelligent, or the very literate or high functioning individuals, again over there, it's very important that you look at the cutoff score very carefully. If you're going to take the MMSE and you take a cutoff score of 24, the many of them who may be having a problem will not come out impaired. So your cutoff scores have to be higher or different when you're looking at the high functioning people. You have to have a greater sensitivity and change your scores accordingly, and change that when you're looking at high literacy. Otherwise, you're going to miss a group of people who are beginning to have an MCI. Also, the age effect, as you can see from these scores, that they shift. This is in the normal high, in the healthy controls. When you're going over the score of 8, the age group of 80, the score is shifting. So your cutoffs are shifting with age. Your cutoffs are shifting with literacy. And you have to be aware of that rather than take one score, which I typically hear from many clinicians, and use that to diagnose. So be very, very mindful of normative data. Now, the challenges of using just one total score. So you think of only one 84, 83 for the ACE, or for the MOCA 26, and you opine on that. But you have to realize that sometimes your total score may be in the normal range. So if you look at the normal range from the Mathuranath ACE, and you do one standard deviation below this total score, this is a normal score in the total range. But if you look at the subdomains and you're looking at this, right away you have the hypothesis, and you're generating the hypothesis that this may be an amnestic MCI. So important to look at the sub scores despite your normal score being all right. Very important that you think of your bilinguals and multilinguals, and you may have to modify some of your test administration methods. Today, Dr. Savarna Aladi and her team with the ICMR battery have come up with a consensus expert opinion that when we do tests like the verbal fluency, for example, or a naming test, in our multilingual and bilingual populations, we have to allow them to go across languages when they're responding. You cannot say, like when you look at the Western population, most of them are monolinguals. They have to answer the test only in one language. But we have to allow our people to name something across languages, whatever language they can think of the name in. In verbal fluency, we give them ka, ma, pa, sometimes in phonemic fluency, and we tell them to generate words. If they tell you the word cake, which is an English word, it's okay, even though they're doing ka. In the English FAS, if they give you the word fata, like broken, in Hindi, it's okay. So allow them to go across languages, because that is the way we have normed our tests for the Indian population. So be aware of these nuances and subtleties, because otherwise you're going to get the wrong scores. The quest of every clinician is, give me a test which I can do in 5 minutes, in 10 minutes, and come to an opinion. I'm very sorry to say, and I beseech all of you all, that at least consider 20 minutes. Please don't come down to 5 minutes and 10 minutes. The ACE and the MOCA are within 15 to 20 minutes. So that's the bare minimum that we have to begin to think about. There are a number of tests, as you can see, that have been listed, but we have to look at what is the test that we have in India which have the norms. And I would refer you to an article by Dr. Porcelvi in the Indian Academy of Neurology journal, where she has listed. And just for your reference, we've just finished writing a chapter for the IAN book, which will be released in the meeting now this year, in which we've taken the trouble to create the whole table with what tests do we have in India which do have normative data. So please refer to tests which have been adapted and have normative data for our population. Going back to Mrs. B, now we found that she repeats questions. Yes, so we are thinking memory, definitely. There's something wrong there. And there's forgetfulness. But look at what the daughter also said. The daughter said, so taking the history very carefully is extremely important for the beginning of your hypothesis to decide that when you're examining with a cognitive tool, what will you make sure that you will examine definitely? Now, she's also saying that she's having some problem with preparing meals, that she used to entertain a lot, have a lot of people, but now she's avoiding that. She's saying, I can't plan these meals. I want to order from outside. I don't want to organize. I don't want to plan. And she's also having trouble following a familiar recipe. So these are little hints or flags or signals for you, and her mood is changing. She's withdrawing. She's becoming quiet, for you to begin to think that something more is happening than just memory. And therefore, it's important that when you take the history, you keep in mind what domain and what are the kind of questions or what are the kind of information that you're going to be getting from the patients. I sometimes recommend to clinicians that have a checklist. So because when you take the history or you're just listening to the history, they may not tell you everything. But when you elicit it later on, keeping this in mind that this is the domain I want to also look at, and you start asking the right questions, then you begin to tease out a history, suggesting that maybe in Mrs. B, maybe there's something a little more than memory happening. So you must have tests which will have multiple domains that you will evaluate. You can't only have a memory emphasis. And that's why the MMSE will not work, because the MMSE does not evaluate executive function. And the MMSE, anyway, at this point, I'd like to tell you, I hope you all understand and know that the MMSE is now copyrighted. So Falstein and group have outsourced it to PAR, the psychology company. And now you have to pay over $1 if you use the MMSE. So you're not really allowed to use the MMSE anymore. It's copyright now. And that's why Mathuranath's wonderful ACE adaptation we had to abandon. And a lot of my work has happened with the ACE. And we're using ACE 3 now because the MMSE items were in the ACE and we had to stop using that. So because of copyright issues. So we can't use scales like the MMSE. So we have to make sure that we have all this evaluated. All these domains, and these are the kind of common tests which come under any of these domains. So if you look at ACE3, MMSE we are not using, you find a lot of repetition, and even in the MOCA of many of these tests, common tests that are used. I tend to use, I'll share with you a lot of my clinical work. I tend to use both the ACE3 and the MOCA in my screening. Because in the MOCA, I find that there are some additional tests, the ones with the asterisks that I've put here, which give me a little more information. When I use the trails, I get a little more of the executive functioning. And I tend to get a little more when I'm doing the language. And in the ACE3, compared to the original ACE, I have a little more of the visual spatial. So every screening tool that is coming out is giving some more tests. Now, recently, there's work happening with the Oxford Cognitive Screen, which is being created primarily for stroke patients. And the Oxford Cognitive Screen has now been standardized in India for a Tamil version. There is work ongoing for the Marathi version. They have many more tests for visuospatial. So as discerning clinicians, you have to have your theory very well. You have to understand that what is the domain that I really want to examine, and then pick and choose your screening tools or try to be more inclusive. Today, fortunately, you are very lucky as a generation that right now from 2000, we have so much data which has come in. Suddenly, there's been an explosion of data and work thanks to the ICMR battery group, the cognitive group, all over the country. There's been an explosion of the neuropsychological tests and the screening tools and normative data for the same, including the very recent testing for the illiterate population and normative data for that. So I urge all of you to get on. It's all in the public domain. Get on to the ICMR website and look at all these tools which are now available for us with the normative data. Let's go back to Mrs. B and start understanding what scores and how you interpret. So on the ACE3 for Mrs. B, now if you go to the ICMR site and you look at the normative data, you'll realize that they've given you normative data or the data which has come from 7 languages, Hindi, Bengali, the various centers that are there. Now, the question as a clinician for me has always been that there is a subtle, slight differences in the scores, the cutoff scores which are given. If you look at the Bengali, you look at the Malayalam, you look at the Tamil, there is slight differences. How do I select which normative data to take? So typically in clinical practice, what I do, I see who's the client in front of me and what is their background. So for example, for Mrs. B, I looked at the Indian English control in that normative data in the ICMR thing. And I found that this was that in the normative data for that Indian English control, it was this normative range for the age, and this was the education. That fitted quite well with Mrs. B's demographics. So based on her demographics, I selected these norms. And now when I look at these norms, so how do I decide? I've taken the cutoff to be at 1 standard deviation below the mean. Now, again, as a clinician, you will decide whether you want to go more with sensitivity. So when it is early stages of the condition, I want more sensitivity. I want my tool to pick up even subtle changes. I go with 1 SD. If you want more specificity, you will do 2 SD, 1.5 SD below the mean, and then you will be able to interpret or decide. So in her case, using the 1 SD impairment range, I did the scoring, and I found that for her, definitely memory was impaired if I take 1 SD below the mean. But I also found that with that 1 SD below the mean, if I'm looking at verbal fluency, it's a borderline. It's not impaired, but it's a borderline. I also found that maybe visuospatial ability was also at the borderline. Now, if I had taken a 2 SD or 1.5 SD, this would not have showed up. But for this case, with 1 SD, I'm seeing, I've just put a single asterisk. I'm just keeping it in mind. I have a story which is telling me planning problems. I have here a score, which maybe it's at the cutoff, just borderline. This is clearly impaired. Clearly, memory is impaired. Okay, so now I do the MOCA. Now in the MOCA, I find that memory, clearly it's a 0. It's definitely impaired in her case. But I'm also finding that she couldn't do the trails. She couldn't draw the cube. So something, but the total score is still okay. It's in the normal range. So if I don't look at the sub-scores, I look on 3 on 5. Okay, this domain is not impaired. And very often in the MOCA, we don't have the normative data for the individual scores. But yes, this seems impaired. So again, I'm thinking that there is something. And look at the cutoff scores. They are different. There is a range from 23 to 25. You have to be aware of that. Okay, so here in her case, I'm thinking memory again, very clearly impaired. But again, this is bothering me a bit. So Mrs. B's physician would, in this case, if you looked at just these scores they would say, possibly this is amnestic MCI. The memory is clearly impaired. So we're thinking amnestic MCI. But when we look at our guidelines for diagnosis, for all of you, you know that we don't only look at these scores. We have to be able to look at what's happening with IADL, instrumental activities of daily living. Functionally, is this person going down? So what are the complaints from the family? What is the person saying in daily life function? What is happening there? Because as you know, the criteria for MCI is intact IADL. You may have one score down, subjective complaints are there, but IADL has to be intact. And you need to rule out that there is no reversible factors. Is there no depression? Are there any medication side effects? Is vitamin B12 low? Hypothyroidism? Sleep disorders? So you have to go through this whole exercise of looking whether there are any reversible factors and rule them out. You have to do your neurological exam. You may decide to do an MRI or no. That is a decision the clinician makes. And you may decide that because you got that query score, sent for a detailed neuropsych examination. Now what happens? So you have to look at IADL very, very carefully. Now, ideal, when you get the history, many patients will tell you, and the story will be that she can do it. She's going out shopping. She's doing this normal like before. But you have to tease it out, that is it exactly like before, or has it become effortful? That's the key word. If it has become effortful, they're doing it, but they're not doing it as well as before. They're avoiding it. It's less than before. It is still a red signal for you. It's a signal for you to pause and think that something is brewing over there, something is happening over there. And if there are mood changes, I still remember a decade ago when I met Dr. Mathranath, and he told me the first thing, that if you get a patient who has first time in the old age a mood disorder, has gone into depression, first time psychiatric symptom, neuropsychiatric symptom, mood disorder, no history before, please become alert of some underlying cognitive change, and that this mood change is secondary to the cognitive change and it's not primary. So be alert about this when you look at the history of that. So you must try and do a CDR, clinical dementia rating evaluation, to stage what is happening functionally. Now, the CDR, I would again urge most of you that there is a training system, free access. Please undergo this training system, because it's how you evaluate this, these different domains, and get the history from the informant, that will finally, what happens if you don't do this properly, the algorithm scores, of course, you have this now, a calculator on the net. You can put in the score for each domain based on your evaluation. But if you have not evaluated in the correct manner, you will put the wrong scores and you will not be able to generate the algorithm score. But when you get the algorithm score, then you can decide whether none functionally, or there is questionable dementia, or there is a mild dementia. Now, another very important thing that not many people do is this sum of box scores. So what I do in my report is I will put all this. I will not only put the algorithm score. Now, for example, in this patient, the algorithm score was 0.5, questionable dementia. As you can see, this is in 2023. 1 year later, the family said that we feel she's worsening. On the cognitive testing, she was the same. She did not worsen. But if I look at functionally and what was the difference in this score, I find that this total score had shifted, though the algorithm score still remained questionable dementia. But this is telling me that no, she is progressing. And I have to watch out for her. And definitely this lady, I can tell you from my past experience, in the next 4-5 years, she will go down the path of AD. She was amnestic MCI. She will go down the path of AD. So these are subtle things which a good clinician will start picking up, because for your prognosis, for your diagnosis, and able to guide the people. Now let's go back to more of her story. Mrs. B, so we can say she had a little bit of dyslipidemia, nothing much happening there. She did have anxiety and depression in the past. It's there in the background in your mind to look at that. But this was important history that you had to find out, that she did have maybe. Now, many of the family members will say, we don't remember our mother and father, but I do remember that she was very forgetful in the end. So you don't know, but there may be history of AD in the mother. So there is a family history which may be positive. Now, everything else seems okay. There's borderline vitamin B12. You will treat that. MRI also is not so significant. It's still a little non-specific. Then we do the neuropsychological detailed evaluation. So we did pick up some tests from the ICMR toolbox. I've mentioned Niemann's here. The Niemann's test battery, I love that battery because it's got 19 tests that I can use. So I can do multiple memory tests to be sure. But the problem is that the Niemann's test battery is only up to 65 years of age. I don't have normative data after that. So it gets restricted. I can't use many of those tests if I have the older population. I went on to, of course, do a proper mood evaluation. This is, of course, the ICMR battery, which I strongly urge all of you to get familiar with and seek permission from the ICMR team and start. I think we need experience from the country and people to write back to us and tell us how it is working, where it is not working, for us to be able to modify it and grow it in a different way as we go forward. So in her case, I also added on some tests from the Wechsler intelligence scale because I have normative data up to the age of 85 plus with the Indian Wechsler scale. So for processing speed, attention, I added on some more tests over here. Now, it's very important as a clinician or a neuropsychologist for me to have some hypothesis in my mind, and then I begin to examine. So I use a flexible cognitive assessment approach where I don't. So when you're doing research, you must have a fixed battery approach because you have to use the same test battery with every patient because you're doing research to compare what it was. But in clinical practice, I play around. So I start with my hypothesis. Now, in this case, I'd like to do more of the memory tests. I'd like to add on more of the executive tests because I have a hypothesis in my mind that's something beyond memory and what is happening to her. Now, in memory, I want to spend a little 2 minutes describing memory testing in a little more detail. So when we talk about memory testing, you have to realize we talk about first encoding information. Encoding information requires attention processing. So you have to pay attention to be able to encode information. So encoding information we capture more in the immediate recall. So whenever you're doing a test, like in the clinic, you do the 3 words, and within a few minutes you say, okay, tell me what those words were. Now, to my mind, actually, we write it as delayed recall, but that's not a delayed recall. So immediate recall in the MMSC and everything, when we talk about it, we say, when we made the person repeat, so we say something and they repeat it, that's actually an attention test. It's not an immediate recall. Immediate recall has to be after a little time and delayed after a much longer time. But immediate recall is still an attention process, and it's not really telling us about the temporal lobe circuits. We're talking more about the frontal circuit. So immediate recall is there. Then you look at the information going into your brain, it getting consolidated. This consolidation process is where really when we are looking at the temporal lobe and we are looking at how information is in those mesial temporal lobe circuitry when we talk about the hippocampus and we talk about consolidation of the information. If consolidation happens properly at delayed recall, the person will be able to recall the information. Then comes we do cued recall, which is the recognition trial. Cued recall is more a retrieval. That means sometimes you will find, this is very, very important, that a person may get a 0 on delayed recall. They say we don't remember. But then you do the cued recall or the recognition trial and they get a full score or a very high score. If they're getting a very high score on the recognition trial, that means the information was consolidated, but they could not retrieve it when you asked for it. So when you gave the cues, they were able to retrieve it. This difference that when so you must have immediate recall in your test, you must have a delayed recall, and you must have a recognition trial. Why is this important? Because when you want to do a differential diagnosis between the cortical and subcortical dementias, if you have retrieval deficits, that means your recognition score is high, even though your delayed recall was low, that is pointing towards a subcortical dementia or a depression profile. So please be mindful and look not only at a delayed recall or an immediate recall and judge the memory. Make sure that you have a recognition trial and what is the score on the recognition trial if a person has done badly on the delayed recall. And you have that in ACE3. You don't have it so much in MOCA. It's only within few minutes you just do in the MOCA also you have the cued recall. So both of them have that. So that's good. Then you go on to the depression scales. I use the 30-item one, but if you're short of time, you can use even the 5-item GDS. It's very good. You can pick up about the depression and the cutoff scores are there. I also use the NPI, Neuropsychiatric Inventory. Now, on my testing with Mrs. B, we found that definitely the verbal learning test, that is the 10-word, the Kolkata battery 10-word test, or which is in your ICMR battery, that means larger list of words, that there was definitely an impairment. And the impairment was both in the delayed recall and in the recognition trial. Also, I found that in the trail making tests of the ICMR battery, there was significant impairment, suggesting to me that memory definitely was impaired, as we said, but there was also something more about executive functioning coming up with the trail B being impaired. And she just did not seem to have any significant depression. So now my diagnosis from amnestic MCI shifted to multi-domain amnestic MCI. Now, why is this important? It's important because we classify MCI into various types. And when we get these kind of profiles, We try to prognosticate who is going forward with what possibly, and we need to track them. So we ask for a repeat evaluation after a year, 2 years. Typically within 1 year, 2 years, the conversion could happen. And within 5 years, we know whether the person is heading in any of these directions. So tracking the progression. So now we have a baseline. It's a very, very important part of neuropsychological assessment to have a baseline so that we are able to track forward objectively. What do we do with Mrs. B at this stage? So use of cognitive enhancers. In my 25 years, I found that in the last, I would say 8-10 years, neurologists are now all giving at the MCI stage, they're recommending donepezil or Adminta, and they're starting the drug. And there is no evidence for this in terms of when we're looking at evidence, except now we have this, the new drug in 2023, lecanemab, which I can't even pronounce well. But this drug has come up and they're saying there's promise with it for being a disease-modifying agent. And there is now work going to start happening, and it's been recommended for FCI. But typically in clinical practice, I find that most people do recommend giving some drug or the other. And then, of course, there are the other things that we do, which are non-pharmacological with the MCI group. And we look at if any reversible factors that we manage. If you do not have the time, so that's about Mrs. B. Mrs. B has been put on Aricept, and we will see as she goes forward. She has a family history. She had something beyond just memory. So we are going to track her very carefully because we think that there is a potential for her to possibly develop the Alzheimer's at a later stage. If you're short of time in your clinic, very, very short of time, two things that I find very useful. This 3-word recall, Minicog tells you, if you get a 0 on a 3-word recall, definitely you're going to start thinking something is terribly wrong, because it's the simplest test that can be there. And clock drawing. Look at your clock drawing. Very often, some people who seem to be well preserved and well functioning, but if their clock, this was just 2 days back, I was doing this with a patient, and well preserved, this lady. And then I suddenly, when it came to the clock, and we said 10 minutes to pass 5, she kept muttering 10 minutes past 5, 10 minutes past 5. And after she did the 5, she was actually trying to draw, and many of them do that. They do 10. They show you the number 10. This concretization of thinking. So when you get, they hear 10 minutes past 5, they go to 10, and they don't show you this too. So this inability for abstract reasoning, concretization of thinking, this to me is a no-brainer. If I'm seeing this in a patient, I'm seeing 0 on 3, then I already, my antenna is up that something is going wrong. The mini ACE I find very promising, but we don't have Indian norms. I would really urge all of us to work for this, because internationally they are finding it a good tool to be done in 5 minutes. But again, what I want to point out to you is if you're short of time, look at least time orientation, look at animal naming for fluency, look at your clock drawing, definitely do at least a 7-word immediate recall, delayed recall, and a recognition trial. So this much bare minimum do to be able to have some indicators about what is happening before you decide to refer toward a detailed evaluation. Now, at the end, I'm just going to very quickly for you go into 5 or 6 cases to show you how we have used these numbers and the scores. These are older cases of mine, so I've used the old Mathuranath's ACE, but it is to just drive home the point of how diagnoses are made on the basis of cognitive scores and tests. So this was a 65-year-old, very senior medical consultant in Mumbai who came to me saying, I'm forgetting names of my junior colleagues. When I do presentations, I've got some word finding difficulties. I have become over-reliant on my diary and on my secretary now to remind me of things. So it's become effortful for me. Now, as you can see in this case, MMSE 29 on 30, ACE 90 on 100. I mean, high functioning person. And you look at I did the whole Niemann battery. He was 65 years old, so I could do it. Across tests, he's in the 80th and 90th percentile. The only thing that stood out was this delayed recall on the word list. Now, this is a 15-word list. It's a very good test auditory verbic learning test. So it's not even 10 words, it's 15 words, 5 trials, delayed recall after half an hour. The delayed recall was in the 25th percentile. In the Nimhans battery, below 15th percentile is impairment. So obviously he's not impaired. So if I look at him, nothing, CDR 0.5, no changes in IDL except this kind of history. So with this range, I would have opined and said, this gentleman, he's normal. He's what we call worried well. We have a category worried well. And because I didn't mention over here, his mother had Alzheimer's. So he had come in concerned because my mother has a history, there's a family history, please examine. I must tell you, in the clinic, I get a lot of people like this now. There's a great awareness happening. So people come in saying, we have a family history and I've become forgetful. Do you think I have something? But for me, this bothers me. That why is this 80th to 90th, everything high, and this drop of the 20th percentile? So despite this score not being in the impaired range, I am still going with the diagnosis of amnestic MCI. And this gentleman, when we followed him up over 5 years, the score shifted. He went into amnestic MCI and then gradually deteriorated into an Alzheimer's. But this was way in the beginning. So what I'm trying to say to you is that when you look at a profile, you have to look at critically at the profile in discrepancy and how it is, and not just go by the score itself. On the other hand, look at this gentleman. He's got similar kind of forgetfulness, other things. But let's look at his scores. Now the 76 on 100, it is when you look at the cutoff, it's 1 SD below, it's at the borderline. So he's still in the normal range. But look at these other scores. At that time, I was not using the the normative data. This is the Consortium for Establishment of Registry of the Alzheimer's Disease List. I've used the normative data from there. And you can see, if you look at this change in IDL, you look at this 2 on 10, recognition score was also impaired, category fluency down, clock drawing down. So this is definitely, now we have got early AD coming from here. Look at this gentleman. Now this gentleman has come with a lot of history about having depression in the past. There's a story of past depression, which he was been treated for. He's gone to the psychiatrist now. Again, he had 10 years back, but now again he has depression. And there was a reason for it, but it was persisting depression. But the main thing was he was also having many cognitive complaints. Now, if I look at his profile critically, I find psychomotor slowing standing out in my domain-specific testing. Very, very powerful over here. And this is very powerful, that I find that his delayed recall was 1, what I was telling you, that the recall is low, but the recognition score is full. When I told you earlier about retrieval deficits happening in pseudodementias or in subcortical dementias. So eventually with him, with these kind of things, we had the diagnosis of that this may still be psychiatric. So I just told the psychiatrist that we need to treat the depression more, but we will track him. We will track him carefully, but there is a history and we will defer the diagnosis right now. This particular lady, what stands out in her story, as you can see, is this naming. When she was naming the camel, she called it an elephant. And she then paused and looked very puzzled. And she told me, but tell me, what does the elephant look like? Here, the giveaway is this performance qualitative, what you observed in the testing. So if you look at her scores again, recognition, 100th percentile. So she's doing well over there. But this is the giveaway in her profile. And as you can see, she was more an FTD, language variant, semantic dementia, and she progressed down there. This is another case. Here I haven't written the diagnosis. I think the diagnosis is clear from the history. I'm just showing you the profile of the case. So this was dementia Lewy body, DLB. The history itself was so suggestive, but this is the kind of profile we got on the ACE. Another case where it was puzzling. We were getting all the language, but you can see from the history, it was more definitely a language variant. And in this case, I did the Boston Diagnostic Aphasia exam in great detail. And then finally, we had the diagnosis of logopenic, one of the rarer kind of dementias. And finally, this was a case which really puzzled us for a while. So again came with very little forgetfulness, again very high functioning college professor, small things, but very high functioning. She was still painting, doing crosswords, traveling internationally, but there was forgetfulness in her mother. The story was there, the history was there. And we evaluated her in May 2022, look at MMSE, look at ACE, 93 on 100, quite good, recall 8 on 10, she's doing very well. The CIRAD, which I use, the consortium, the memory test, 20 or 20, delayed recall, everything wonderful. And again, now we repeated in later on because she said, I'm having these problems and y'all are not paying attention to my problems. So we repeated it. And then we found again MMSE, good. ACE, yes, a little drop, but still good. No problem. This is a repeat test. And then in the CIRAD. So what I want to show you here is that as long as we did 7 words, 3 words, 5 words, no changes. They were fine. They were still performing well. Now, when you look at very high functioning people, this is what happens. Then when we went to the 10-word list, we saw this drop. Very significant drop. We saw this drop. And then in my enhanced battery, when I did this passages story recall, she was at 70th percentile in May. Delayed recall was at 90th percentile, and she dropped to this. So finally, after going into more in-depth testing, we were able to see that there was an MCI definitely happening. So do not ignore the patients and the relatives' complaints if they're coming to you. Don't disregard them when your scores are not there. And on the other hand, don't over-regard them, taking one cutoff score. I was just sharing that yesterday I had a message from someone from North India, one of my close friends, and she went for an evaluation. And she got a MOCA 28 on 30. And she said, I was a bit confused. I did do the serial subtractions well. So she had a score of 28 or 30. And the neurologist there had started her on Aricept. So you get a score of 28 or 30, and you have that cutoff in your mind, and you say, oh, it should be 30 or 30. She's high functioning. And you start Aricept. And her complaints were also not so significant. So please look at it in a multidimensional manner. So what do I say? That if you get your scores in the normal range, in your quick screening tools, but there are significant subjective complaints, they keep telling you, no, there's a problem. I'm different from who I was, especially in these high functioning groups. There's a family history of dementia, first time history of mood changes that are happening. IADL is adequate, but it is effortful. And they are beginning to withdraw and not communicate, and they're becoming different. Please do a detailed, proper evaluation and think about these cases. Neuropsychological evaluation is multidimensional. We help you with the diagnosis. These tests help you with the diagnosis to be able to decide whether it's normal aging or it is much more. And the types of dementias or the types of MCI helps you rule out depression, pseudodementias, helps you prognosticate, you track the progression with the baseline evaluation, and your profile, which we've not talked about, of strengths and difficulties, helps you plan the rehabilitation and the cognitive enhancement strategies. And finally, we are getting a lot of referrals now for creating a will, for inheritance issue, for competency evaluation, where there are medical legal implications, where you need the cognitive testing. So with this talk, let me pause over here and thank you for your attention and questions. Of course, there are a lot of things which I have not covered, but I wanted to take you through this journey of what we are seeing in the clinic and how to opine on that. Thank you very much for your attention.
Thank you, Dr. Rubosisa.
Yeah,
as always, an excellent lecture. And of course, I hope the residents and the junior faculties, as well as those seniors who are listening, have learned a lot how to approach a person who is coming to the clinic with some memory issues or some other cognitive issues, and how to proceed for that.
Thank you.
Dr. Fahim is also here. If you have anything to discuss, I think there are few questions. Dr. Sam, probably Dr. Sam Prakash has written how is IADL? What is the difference from the ADL? And do we have any objective scale to assess the IADL?
So the ADL stands for activities of daily living, which are more the simple self-care activities. So bathing, toileting, feeding, those basic daily activities is the person independent in or has become dependent. Typically, you will see that your ADL gets affected as the disease progresses. So when you have moderate dementia, when you go to severe dementia, then you will start getting that history. So even in your CDR scale, you will see that when it comes to this, that 0 is that they are adequate. But when the family tells you that I have to prompt them, I have to remind them to go, or when they are going and bathing, their hygiene is not so good. You look at grooming. So now it's not about just going and bathing, but they're not shaving properly. When the lady comes to my clinic and I watch first how she's dressed, then I ask the husband or the family, did she select her clothes? Did she wear the jewelry? Did she comb her hair and come? Was she independent or did you dress her? So this kind of subtle changes that happen in your self-care, that is ADL, that comes much later. The decline comes later. IADL, instrumental activities of daily living. If I look at a male or a man who comes to me, I ask questions more related to, say, banking, finances. So does he go to the bank still? Does he manage his accounts well still? If I'm looking at a lady, I'm going to ask cooking. Is she able to do her cooking still? Is she going out shopping? Do they go out shopping? Do they go marketing? Are they able to entertain? Are they able to plan those meals? Like the lady who said that, many often they'll tell you when they're older, they'll say, first she would have a multi-course meal, but she'll say, now I can't plan that. I can't organize that. Then it comes to the mistakes in the cooking, like she's not put the salt. So instrumental activities of daily living are ones which require higher cognitive level. They're beyond basic, which you do need to function in daily life. So many times you will get the story that they are now not engaging in their home and hobbies. That's why in CDR, you have home and hobbies, one thing where you rate. That she's not doing the things she did before, or he's not doing it anymore. So that's the part of IADL coming out. And now in the community, when you do the CDR, they're not going out alone to the shop to buy, to the mall to buy. They're taking someone with them. These are all the indicators. So that's instrumental and that's ADL. In the early stages, you have to elicit IADL very well. In the later stages, you'll see ADL also going down. I hope I'm
next. Yes,
scale. Yeah, there's a scale in the ICMR battery. Now we have a scale for IADL.
The second question is it okay to use the term dementia with DSM-5 being in vogue for more than 10 years now?
Very good question. We've all become very politically conscious about the words we use now. I think across conditions, we are very careful about what words we use. So the word dementia was rejected by the DSM-5 committee. I remember reading a lot about this. Dr. Jeshte, an Indian from us, was also a part of that committee. And they talked about it having a pejorative or what we call derogatory kind of label, the word dementia. Because in casual language, we say, oh, you're demented to each other. So the word dementia had that pejorative term. So that's why that committee had decided that we should not use the word dementia. We should use the word major neurocognitive disorder or, the minor neurocognitive disorder. So I agree with you. Maybe I was wrong in even titling this talk about dementia evaluation. Maybe we should now be more politically correct and not use the word. But these are semantics, finally. They are words that we are using, like we use the word pseudo seizures, which now we're very, very particular about not using the word pseudo seizures and using non-epileptic attacks. So it's a good question. I think as we go forward, the word dementia may disappear. And the interesting part is that in the Indian scenario, we don't even have equivalent words in the languages for dementia. I've always wondered, is it because we don't even think anyone has dementia? We just think that our elderly are just part of their aging, are losing cognition. So we don't even label them. So yes, that's an interesting question. Thank you.
The next question is, when do you take your patient for CRAD?
Sorry, where?
take your patient for CRAD, the battery assessment?
I use, so the CIRAD stands for Consortium for Establishment of the Registry of Alzheimer's Disease. It's a battery of tests again, of which the memory subtest is just one. The reason I started using the CIRAD was because, as you saw in my CV, I worked for 5 years with a team from Mount Sinai in New York. This was a part in the Nair Hospital in Mumbai. We had a project where we studied this cognitive testing in the elderly in Mumbai. And at that point, the ICMR battery was not out. The Kolkata battery was out, the 10 words, but we had used the CIRAD words, which the Kolkata battery words have been taken from the CIRAD itself, so has the ICMR. And we had used that, and I got familiar with using that particular CIRAD battery. In my clinical practice, as I showed you in one of the slides, when I think of evaluating memory, I will do 3 words. I will do the 5-word from the MOCA, so I get the 5 words recall. I will want to do 7 words from the ACE in the address. And all this up to 7 words when you're doing a recall, they are what we call immediate auditory attention span. So for me as a neuropsychologist, that's your immediate auditory, what we call plus or minus 9. That's your immediate auditory attention span, working memory when we talk about. I always want to examine what I call supraspan learning. That means beyond 9. Okay, so there I need a list which is beyond that 7 words. So ideally, I like my 15-word list with AVLT. I'm very happy with that. But the 15-word list, as I told you, we don't have norms in India for the AVLT beyond 65 years. I'm hoping somebody will undertake that and give us norms for all those 19 tests. But we don't have it. Dr. Shokni Rao did up to 65 years. So the 10-word list I like. I like very much because it's supraspan learning and it has good recognition. The hits, the omissions, the commissions. I go into that. I didn't have time here to talk to you about it. Just the other day, one of my junior colleagues told me that the recognition score is low, but the person had full hits. So there's nothing wrong. So I said full hits, but what about the commission errors? So there were commission errors. Please understand this. So the person, while answering in the recognition trial, 20 words you read to them, 10 are target words, 10 are other new words that you have mixed up. They have to answer yes or no. So the person actually had said yes to almost all of them. So even words which were not there, he said yes. So he had commission errors. He said yes to the right words also, but actually he was just saying yes. So if you qualitatively watched him, he had just said yes. So it was random answering. But his hit score was 10 on 10 because he was just answering yes. So my young colleague was saying, but ma'am, he answered all the words correctly. But he also said yes to all the words which were not there. So you have to understand that, so it's not about, so you have to understand in the CIRAD, how do you pull out these aspects? So I love the CIRAD. You must, if you can, include from the ICMR that 10-word thing and look at the norms. The 10-word list is important. I don't know whether I've answered the correct question. So many more questions coming up. Okay.
I think we have many questions, but we won't be able to take them all, Dr. Atanu sir. But I think, Dr. Urvashi, I would request you if you could type them while we are in the next session, because many people have asked some queries and there are compliments as well. We can take the compliments, but maybe we can answer their queries while we go into the next session. Dr. Atanu sir, you are muted, sir.
Yeah, because you have the next presentation. I'm sorry, I took so much time.
Atanu sir, you're muted. Yeah.
Thank you very much for your personal experiences sharing with us, and also the qualitative aspect of the assessment is very important for the clinician. Now we will move on to our next part of this webinar. Here a case will be presented by Dr. Anirudh Srivastav, and his mentor, Dr. Ashwini Bhatt, will be guiding him. Dr. Ashwini Bhatt is currently the Associate Professor in the Department of Neurology at Himalayan Institute of Medical Sciences, Dehradun. He completed his DM from our institute, the Bangalore Institute of Neurology. He has several publications in very reputed journals, particularly his works in the field of vascular dementia is worth mentioning. And with him, his resident, Dr. Anirudh, will be presenting a case, a very interesting case. I request Dr. Anirudh, he is currently doing his DM Neurology at Himalayan Institute of Medical Sciences, Jolly Grant, Dehradun. And I hand over this to Dr. Osini and Dr. Anirudh to begin the case presentation.
Ashwini, you're muted.
Yeah. Thank you, sir. Thank you, sir, for this opportunity. And thank you, ma'am, for this enlightening talk on the cognitive assessment for clinicians. So, due to the brevity of time, we'll start with this painting. This is art which was one of the very first impressions of what is known as Impressionism. Why I have kept it here will be discussed by Dr. Anirudh subsequently. But what I want to extrapolate from this is that sometimes we are faced with difficult clinical situations like rare disorders or common variants of rare disorders, or not very often rare variants of rare disorders. In such situations, it is important to delineate different domains involved and then arrive at the most probable diagnosis, like the strokes of brush here. Subsequently, use the cognitive assessment tools as was shown by respected ma'am, and the dictum remains the same. Where is the lesion? What is the lesion? Why is the lesion? But it is these batteries and tools that later on help us to actually delineate the lesion and then arrive at a particular diagnosis. And another aspect to this dictum is that how is the lesion, or how is the lesion behaving? How is the patient behaving? What is the functional status of the patient? So that, as madam said, we can arrive at that from CDR and many other tools like that. So I'll pass the mic to Dr. Anirudh to start this interesting case presentation of a case of a tale of distorted reality.
So good afternoon, everyone. At the outset, I would thank the IN family for giving me the opportunity to speak on this wonderful case which this case had been presented. And really, I feel this is a mirage, tale of distorted realities. So I wanted to present it. This patient had presented to us who was a 55-year-old female homemaker, right-handed, and speaks Hindi and Garhwali, understands Hindi also and Garhwali also, but less of Hindi. Resident of Uttarkashi, Hindu by religion, had presented with following complaints. The first complaint which she presented was she had inability to recognize objects and familiar faces since last 4 years. Second complaint was, as the disease progressed, the second complaint was she had difficulty in navigation since last 3 years. Third complaint was she had difficulty in doing day-to-day tasks since last 1 to 1.5 or rather 2 years. And last but not the least, the complaint was she had loss of interest in the previously pleasurable activities, and that had been recently since last 1 year. So to start with, I'll start with my history of present illness. This patient had presented symptoms started in the COVID era. Now, the COVID era, she was there, everybody was hostile in the home, and the relatives started noticing that she's unable to identify objects just by looking at them. She said that patient started to have difficulty in identifying objects, but however, she was able to recognize it by touching. On asking whether she was having knowledge of the same, she said yes, she was able to explain the object given to her. Furthermore, she as the disease was progressing, she was saying that she had difficulty in recognizing familiar faces. She sometimes was not able to recognize her husband or her daughter, but by voice she was able to recognize, and the emotions of them were preserved. That is, she was not behaving in a bad fashion with them. Next complaint was, as the disease was progressing, within 3 years ago, she had started difficulty in navigation. Now, what the difficulty she was having was, she used to get lost in the house. Whenever she had to go to the kitchen, she would rather go to the bathroom. And this was not once. This had been twice. She would be lost in the house. She would also rather be lost in outside the house also. Whenever she used to intend going outside for the park, she used to go somewhere else. Then you should call her son or daughter, and they would take her to pick her up. So these were the complaints she was facing. Furthermore, within that era, that period, 3 years ago also, she had difficulty in climbing stairs. In a very weird fashion, the relatives diverged that she used to climb 2 stairs at a time, sometimes one, sometimes two, and she was not able to she was not able to judge the depth or the how much the height the stairs were. So these were the complaints which were there. Now, initially, relatives thought that this was more of an ophthalmological problem, and they went to a nearby ophthalmologist. After doing a serial ophthalmological examination, it came out to be normal, and this patient went to some nearby neurologists. Furthermore, as the disease was progressing, patient started having difficulty in doing day-to-day tasks. That is, she started having effortful ADLs. Now, the first thing is she was able to do it, but with effort. She could do it with effort. First complaint I would like to elaborate was she had difficulty in opening and closing the bottle cap. Now, whenever she was thirsty or wanted to drink water, she was unable to open the bottle. She would ask the relative to open the bottle, then she would drink the water, and then again she would be clueless how to close the bottle cap. Initially, this was not there before the COVID era. Now, this was a new complaint which the relatives had been facing. Secondly, she was a worshipper of God. Every day she used to worship God. But now the relatives started feeling that whenever she used to worship God, she was unable to light the diyas. What she would do is she would catch hold of a matchstick and matchbox in one hand, but was unable to do the action of lighting the matchstick. Furthermore, she was fond of playing football with the neighborhoods. This was the complaint given by the relatives that she used to play football with the neighborhood. But since last 2 years, she had difficulty in kicking the football, and she would use her hands in kicking the football. Next complaint was she was a really good cooker. She was a really good cooker as well. She used to make the dough of the chapatis. For the chapatis, she used to roll it also. But relatives started complaining that she used to not keep it on the pan. She would keep it somewhere else. She would keep it on the floor. And it was very astonishing for them. Furthermore, everything was going on now till she started having difficulty in dressing as well. Now we have to understand this. Her insight was present. She knew that she had to wear the dress and how, but whenever she used to wear the dress, she used to wear it inside out, or she put her hand sleeves in the leg sleeves and leg sleeves in the hand sleeve. But she would not keep it like that. She knew that she had done the wrong dressing and would ask the relatives that she had done it wrong and would help her doing it. Further, wearing the slippers also, this was the same complaint. She would wear it upside down and would ask the help of the slippers. So the inside of the patient, very importantly, was present while doing the ADLs. Last 1 year, 6 to 8 months rather, so she had started having loss of interest in her previously pleasurable activities. She is really confined to herself, not talking too much to the other relatives. She was very fond of going to gatherings, but now she has stopped going to any sort of gatherings. Her sleep habits are normal. Her appetite is normal as well. The relatives denied any history of suicidal thoughts, low mood. And as I already told, the inside of the patient was preserved. Negative history, there was no history of any motor weakness. There was no history of any ataxia, no history of any sensory involvement, There was no history suggestive of any cranial nerve involvement. There was no history suggestive of any bowel and bladder involvement. And there was no history which was suggestive of any episodic memory loss. Very importantly, there was no history of asymmetry. There was no history of slowness of movements. There was no history which was suggestive of inappropriate social behavior. There was no history of abnormal body movements. There was no history of hallucinations, no history of any delusions, and no history of any fluctuation. There was no history of just any auto. And the last psychological diagnosis, there was no history of any in the past. There was no loss, no history of any constitutional symptoms. Past history, patient is a hypertensive since last 8 years and was on regular medicine. She is a vegetarian by diet. She is having normal bowel and as already discussed, and there were no addictions. This is a family history. Socioeconomic history. She lives in Uttarkashi. Housemaker by housemaker, supervises in farming initially. She lives with her 4 brothers and sister. And according to a modified Kuppuswamy scale, scoring was 21. That comes to the upper middle class. To summarize with, I had a 55-year-old female present with a past history of hypertension, inability to identify objects in familiar features. So this, we had thought that this domain affected in this patient is visual / agnosia. Most probably it is visual perception, but we kept it as agnosia as well. Secondly, she had difficulty in navigation, and she used to get lost in the house, lost outside while going to the park. So we found that the domain affected in this patient was visuospatial, and this was progressing. Furthermore, the learned activity she was not able to do. Whenever she was asked, she was this object, but she was not able to conduct the activities. And this was within 2 years. And the last complaint, since the last 1 year, she had started with having loss of interest in hobbies and valuable activities, and we would attribute it to be either apathy or depression. So that is a bit confusing thing. And as well as she presently requires doing all the activities of daily living with assistance. So I would like to.
Dr. Anirudh, can we take a pause here? Yes.
I beg your pardon, sir.
Can we stop here for a moment? Before we analyze the patient, yes.
Yeah.
I have stopped, sir. Yes.
So this patient presented to us with visual complaints, predominantly in the form of visuoperceptual deficits, followed by progressive visuospatial deficits, which were slowly progressive, and later on followed by a praxis difficulty. And as we can see, she had a mood disorder, or behavioral domain was also affected, most likely apathy. So first, I'd like to request our senior faculty for their valuable comments on this case before we analyze the patient.
Dr. Biswas, will you go ahead?
To me, it is a young lady, relatively almost a decade before the usual age of onset of dementing illnesses. We see many patients of young onset dementia in our country. Many degenerative dementias, they do come in early age because of probably the early aging of our countrymen. But when dementia sets in a patient of 55 years old without any family history, it is probably a sporadic form of degenerative dementia. But here, what type of dementia this form is very important because it is non-amnestic. The episodic memory is not affected till almost 4 years down the line. of the disease onset. Whereas the domains which are affected are mostly the sexual disorder, the spatial disorder, difficulty in navigation, as well as difficulty in using the tools, the praxis. So most of the domains which are affected are the parieto-occipital, the occipitotemporal, and these are mostly the posterior part of the cerebral cortex which are affected. There are also one important institution was having difficulty in going stairs up and down. So this was probably another important aspect of the higher order visual dysfunction. So all these taken together, there was little affection of the hippocampus or the hippocampus, but more affection is in the temporal and parieto-occipital and temporo-occipital areas, maybe bilateral. And in these patients, of course, we try to look into whether there is any asymmetric Parkinsonism or there is symmetric Parkinsonism. As from the history, there is no slowness or Parkinsonian feature. Whether there was any history of RBD or any fluctuation or hallucinations. So the possibility of a Lewy body pathology is less likely, and also the CBS because of the lack of asymmetric Parkinsonism. So the possibility remains is a atypical form of Alzheimer's pathology in this patient. This, in my opinion, I think Dr. Fahim is also here if he has anything to say.
No, sir, thanks a lot, sir. I completely agree with you. It is likely an atypical form of dementia because hippocampal involvement is not there at the onset. So I think Dr. Shah,
Yeah,
madam, you want to comment?
I just right away the thought came of the posterior cortex,
Hmm.
and because of the visual perceptual thing, and also about faces and could hear and understand. So when I just heard that first, I was thinking fusiform gyrus, I was thinking of those areas, post-hypnosia, and thinking that, but then it evolved and it's grown now into the apraxia. So I'm wondering whether it's something which started in a certain region, that whole temporoparietal occipital, like a little more wider region, because I'm seeing it progress into, with the apraxia coming in. And also this apathy struck me, with apathy coming in as rather than the anxiety or depression, but strongly, but the apathy component also made me wonder about any subcortical component. So just for the few things from the history that stood out for me. Large posterior, spread out now, progressing, so at the apathy.
Thank you, ma'am. Thank you, sir. So what is important here is that the patient started, yes, she started with affection of the posterior cortex predominantly, the what and verb pathways, the ventral and dorsal visual pathways. And history-wise, the deficit was significant. But as we can see, to begin with, her ADLs were not impaired. She was doing her activities of daily living like cooking, household work, even her basic as well as some instrumental activities which she was able to do. But once she started having apraxia, the ADLs, they started becoming impaired. And despite having good memory and executive function history-wise, she couldn't even perform her basic ADLs. She was comfortably sitting in front of us, but with good insight and yet unable to recognize things. And we think that this insight might be one of the reasons, as Madam said, for her apathy. Generally in patients of posterior cortical atrophy, the insight is preserved. So compared to conventional or typical AD, the insight is preserved. So in these cases, the apathy or the anxiety in some cases might be reactionary or not a part of the disease process per se. So we have localized the disease process to posterior cortex predominantly, and yes, the pathology was degenerated, like sir said. We ruled out all the other causes. She didn't satisfy the criteria for, although criteria and temporal course of events, they don't substitute the clinical sense. But yes, she didn't satisfy the criteria for dementia with Lewy bodies or corticobasal syndrome. There was no asymmetry history-wise. So we kept a diagnosis of posterior cortical atrophy. A degenerative pathology, a typical variant of Alzheimer's disease, most likely posterior cortical atrophy. So I like to pass the mic to Dr. Anirudh.
So we, as already discussed, just wanted to localize the domains which were affected. So visual perceptual dysfunction, for starters, it is the ventral stream is being affected, and that, as already told by Dr. Ashmi sir, it is a ward pathway, and it consists of passing from inferior occipital cortex to the inferior temporal cortex. The dysfunction is there. Then the visuospatial dysfunction, most probably it is involving the Ware pathway and involves the dysfunction passing from the superior occipital cortex to the parietal occipital cortex, non-parietal lobe. The apraxia, as we can see, bilaterally left and right parietal lobes are involved. Whereas if apathy is concerned, anterior cingulate cortex versus medial frontal lobe cortex, we have kept it, and these were the structures involved in this case. According to us, most probably our diagnosis was degenerative, as the history is chronic, and there was not fitting in any sort of other etiologies. And till now, we can feel that this is a non-amnestic variant of Alzheimer's, that is the posterior cortical variant. And we further started with the general examination. So when we started with the examination, patient was sitting comfortably on bed. Her vitals, pulse rate was almost normal. It was regular. They was having the normal volume, normal rhythm. Peripheral pulsations were present. There was no carotid breathe. We checked for autonomic dysfunction, orthostatic hypotension as well. We did a lying down and standing blood pressure, which was also unremarkable. No pallor, no ictus, no cyanosis, or no clubbing. The skull and spine was normal, and there was no neurocutaneous markers. Now to our favorite examination, that is the MMSC and the other exams. So HSMC came out to be 15 by 27 letters. Delineate what marks did she receive in MMSC. For as far as orientation is concerned, she secured a score of 4 by 10. She was able to name place where she is there, and was able to name the season and day. Registration, she was able to register all the 3 words, unrelated words, which were given to her 3 by 3. As the patient was illiterate, she could not do the calculation, so we could not score her on that. Recall. So this, I want to highlight the point is, initially her recall power was very good. There was no problem in recall, but now to 1.5 months, 2 months ago, now she had started with difficulty in recall. However, when we are giving the cues, she is able to recall. Language, she secured a score of 7 by 9. So total score in MMSC was 15 out of 27. We did the age scoring as well. So this is how this age scoring was done for this patient. And we saw that in attention, she secured 6 points. Memory, she secured 5 points. Fluency, she secured 6 points. She was not able to do any thing in visuospatial. Language, she secured 4 points. So out of, for this patient, as patient was illiterate, the total score was 21 out of 88. Next domain which we tested was attention. For digit span, she was able to do forward digit span of only up to 2, and backward span she was not able to do. Word spelling backward, as patient was also, she was not able to do, and patient was illiterate. Language, her spontaneous speech was present. Her verbal fluency, she was able to name the animals in 1 minute normally. Comprehension, simple and complex commands were also, she was able to follow, and that was intact. Naming, she was not able to name the things with touch. With just seeing it. She was able to name only by touch, and reading and writing, she was illiterate, so we could not touch that domain. Memory, her immediate memory was intact. Her remote memory was also intact. When we asked about the autobiographical memory, she was able to recall her marriage date. Now we did a very detailed examination of visuospatial with line bisection, and this is done by the patient itself. And you can see that the line bisection is done slightly on the right side. We asked her to do it on the center, but slightly on the right side, or not very properly. Second is the star cancellation. There were others which were big and small. However, she wanted to identify that it was a star. Unable to use pen to cancel them. Nextly, we asked her to copy squares, stars, and flower. She had made, she couldn't do it. This also, when asked to copy the various shapes, she was able to draw them in air. Like for example, we asked to make a circle, to make that in air, but had difficulty in making on paper and drawing it with pen. Colors, domain which we tested was visuo-perceptual. So identify colors and matching them. She was able to identify 3 colors correctly out of, but was unable to match them. Identifying and matching objects. So this is very important. When this patient came to us 3 years ago, she was not able to identify by seeing it first at touch. But now when we did it 1.5 to 2 years, she was difficulty in identifying it with touch as well, and matching out of the question. She was not able to match them. So we asked her to match the objects with the object on the extreme right, and she was not able to match it as far as function is concerned of the object. Then she was able to identify it is this photo, but was unable to what was there in the photo. So this was also could not be performed by the patient. Benton's facial recognition test, and this also could not be performed by the patient. Then mixed figure testing for ventral simultagnosia. She could not identify or delineate any of the pictures which was shown to her. Cookie theft test. She could not do these tests as well. We went for Gollin's figure and steroids as well. So no part of the picture could be identified by the patient in Gollin's figure, and the shadow as well could not be identified by the patient. So this was the test for visuospatial and visuoperceptual. Optic ataxia was positive. She was unable to touch her ear and then touch the examiner's ear, and that was positive. However, oculomotor apraxia was not present. As far as praxis is concerned, we asked her to identify certain common gestures like action of brushing her teeth or waving a goodbye. She was able to identify the gesture, but was not able to imitate it. Sequencing of action, she was given a matchbox and matchstick and asked to take out the matchstick from matchbox and light it, but she could not do it as well. However, she had the knowledge of the items. Lastly, the frontal lobe testing, as discussed, digit span was she could do up to 2, and backward she was unable to do. Trail making test could not be expected because she was illiterate. Sequencing, motor neural test she could not perform as well. Go-no-go test, she had done it with a lot of difficulty. Go-no-go test as well. However, judgment and abstract thinking she was able to answer when asked about the scenarios for judgment and abstract thinking. We did a Hamilton scale for depression and anxiety. And we found out that anxiety was predominant as far as, and depression was not there. We did NPI scaling also, and severity came out to be mild to moderate. We did clinical dementia scale, rating scale also, and this we did before and after. So this was this scaling was done 2 years ago, and this initially it was 1, and now it has progressed to 2. So see, a clinical dementia scale has progressed from 1 to 2, anxiety and mild to moderate severity in NPI scaling. As far as other neurological examination was concerned, there were the cranial nerves were normal, bulk motor examination, bulk was normal, tone Now, initially, the patient, when she had presented 2 to 3 years ago, in 2021, lately, she had no rigidity. But 6 to 8 months ago, when she came, when we examined, she had started developing cogwheel rigidity on the right side. Plus point, which was there. Then power was normal. Reflexes were not exaggerated. Plantars were also flexor. Sensory examination was also normal. Very importantly, cortical sensations. So we wanted to look for cortical sensation. Initially, when she presented to us, it was normal. Then she was lost in follow-up, and then 6 to 8 months ago, when she had presented again, the cortical sensation was abnormal, and she was not able to do the cortical sensation was abnormal. Cerebral examination was normal. When we examined for gait, the left arm swimming was reduced. There was no fascination. There was no shuffling. Posture was also not stoop. However, now this initially, if we compare it from the first visit and 6 months ago, patient had bradykinesia. So she had started having the slowness in movements and mild slowness in walking, which was not there when she presented to us in the first visit. Peripheral nervous examination and ENS was also normal. Systemic examination, all systems examined were normal. So additional findings after examination was 6 months ago, she had started developing cogwheel rigidity on the right side. Cortical sensations now have started becoming impaired, optic ataxia being present, visuospatial and visuoperceptual, which was already discussed, is also affected. And for now, we cannot make your. So I would like to hand over this to our panel about the final diagnosis, and then we will see for the probable diagnosis.
Thank you, Anirudh. So, what additional findings did we get after examination? The patient had already, we know on history that the patient had visuospatial and visuoperceptual dysfunction. Patient had a deficit in attention, most likely maybe due to the affection of, we assume due to the affection of frontoparietal pathways. And another important aspect was apraxia. That too was present on history. But what additional findings we had was cogwheeling that was present on the right side. There was bradykinesia. 6 months back, we examined the patient on a video conferencing, and we suspected that the patient had bradykinesia. Then 2 months back, when the patient came to us, the patient had she had cogwheeling on the right side. Followed by, we also examined the cortical sensations. They were absent because patient had also absent cortical sensations. Another thing was the go-no-go and motor luria. The patient had severe apraxia. As we can see from the visuospatial and visuoperceptual figures, patient, although she was bisecting the right line on the right side, but she had difficulty in even using her hand. To begin with, this was not there. 1 year back, this thing was not there. So the new findings were cogwheeling, absence of cortical sensations, and then the bradykinesia on the right side. So I'd again like to request Tanu and ma'am for their valuable inputs.
Thank you for Anirudh for presenting a very good case. What we have analyzed from the history, we have confirmed that by showing the impairment in various domains, particularly the visuospatial, visuoperceptual, praxis, the gnosis. But also there was some amount of executive functional loss and loss of attention. So clearly suggesting that there is dominant affection of the parieto-occipital, temporo-occipital cortices on both sides. But additionally, there are some motor features which are appeared in the last examination, and this is more asymmetric, more so on the right side, and also there is some the parietal dysfunction in the form of cortical loss. So what appears from the history was a degenerative disease, and without any motor feature, we are thinking about primarily a posterior cortical atrophy variant of Alzheimer's disease. But now it is a posterior cortical atrophy plus there is some additional motor impairment and cortical as well as subcortical affection. So there might be a component of CBS, cortical basal syndrome, in this patient, which was not there at the beginning, but is now developed. And we need to investigate and see about imaging and other modalities of investigations. Dr. Urbosi and Dr. Fine, please comment.
Dr. Urvashi, you are muted.
I said very interesting case, quite atypical. So I, in fact, have a question more than anything else. So I can clearly see the degenerative process. So we started with more the posterior cortex and the presentation coming there. But now, as Sir has said, the attention, the executive aspect, the frontal are getting involved. So I'm curious to know from all your experiences that when the pathology spreads, somewhere it started in the posterior region. Now we're talking about cortical, subcortical, we're talking about frontal. How is the trajectory? How does it spread? I mean, we're seeing relative sparing of maybe like the memory is still, they're saying that it's relatively impaired. So I'm putting a question, in fact, that what is the literature? Do we have any understanding that where the pathology is spreading like this? Like in Alzheimer's, we typically, when we see first the memory part of it, then we see the executive coming in, then the visual perceptual. So there is a kind of a sequence of how domains start getting involved. Is there any thought of how possibly this is spreading and why is this it's looking a little all over the place? Any thoughts, anyone with any idea?
One aspect is the pathology that is spreading from the starting from the parieto-occipital areas and spreading to the subcortical basal ganglia, and that itself, affection of basal ganglia, is probably responsible for this frontal subcortical dysfunction. And also there is a frontal parieto-frontal connections which is getting impaired, so the patient's attention is getting impaired as well. So that is probably in my opinion, is the explanation for having the executive dysfunction in this patient is presented primarily with parieto-temporal, parieto-occipital and dysfunction.
So, sir, is that the typical progression we see with posterior cortical dementias? Is that a typical progression?
Posterior cortical atrophy, if we say the Alzheimer's variety, they usually do not come with the motor feature, and they in the long run they usually they start in the focal parieto-occipital or temporo-occipital areas, but the pathology spreads to the temporal, medial temporal, as well as the frontal areas in the long run. So they in the follow-up, we get to see the all domains gets affected.
Yeah.
But but for the pathology of CBS is heterogeneous. There might be Alzheimer's pathology as well. There might be some other pathologies like the seen frontotemporal dementias like NAPTAO or other pathologies. They can begin with a focal disease in the parieto-occipital areas or the parietal areas, and they spread pathology spreads to involve the basal ganglia, and of course they sometimes do spread to other areas as well, but they usually spare the hippocampus. They do not come with the memory problem as such.
Yes, sir. Yeah, so thanks for those comments. I think, as you said, just to add, why this is posted PCA plus, as Dr. Ashwini has put it, because of involvement of other domains, and the pathology as it usually doesn't go in typical PCAs. But when it goes to other lobes, it involves the other domains. That's why we call it PCA. So it's basically mixed pathologies, ma'am. We have mixed degenerative pathologies as well. Because we have seen there are cases who come with PCA, they tend to develop other symptoms as well. Some develop frontal lobe symptoms and some develop visual hallucinations, some DLB kind of symptoms. But they don't have typical DLB things. They everything, whatever they have is PCA, but they have additional symptoms. So that's why we call it PCA plus, but they can have mixed pathologies as well. They can have synucleinopathy. Even there are cases where they've reported them as having tauopathy also, suggestive of an FTD pathology. So it's a mixed kind of a degenerative pathology, but I think the $1 million question still remains why it happens. I mean, we don't know. Still, I think lots of research is going on. I think the answers are still not there. So Ashwini, yeah, maybe you could.
Yeah, should we continue with the investigation?
Yeah, please.
Yes, Anirudh. Can you give a brief
So to
resume of the
start with,
investigation?
yeah, to start with the investigations, the baseline investigations like metabolic panel, vitamin B12, thyroid, everything was normal, and it was unremarkable. Let us start with the CT scan, NCCT brain. So we can see here the patient has bilateral parieto-occipital atrophy, which can be seen more on the right side as compared to the left side. We did an MRI brain also with in our institute, and this is the MRI brain. I just had cut out the various images. So this was the T2 axial image. The second one is the T1 axial. Then is the flare images, DWI images, the ADC images, and T2 coronal. We could see that in the MRI, there are prominent cortical sulci in the bilateral cerebral hemispheres, predominantly in the posterior parietal regions. So in the bilateral posterior parietal region, there are we can see that there are the prominent cortical sulci and occipital lobe with evidence of loss of parenchymal volume. Rest, there is no other focal deficit thing which we can appreciate in MRI. Then as we had already told, that patient was lost in follow-up. Outside, she went for FDG PET scan. Let us see the FDG PET scan as well. In this, we can see that this is how, so the posterior cingulate cortex started involvement. There is hypometabolism, which is there, cuneus, precuneus. And you can see that there is moderate to severe metabolism in bilateral post-parieto-occipital region. So we can see that there is more bilaterally parieto-occipital region. There is hypometabolism, which is there, as we can see. And most importantly, we can see that the sensory motor cortex, the bilateral cerebellum, are spared. This is a very, very important finding for Alzheimer's disease. And to be more particular, in the posterior cortical atrophy, we generally get FDG PET scan in this. Patient also went for F-DOPA. F-DOPA was not showing any sort of, it was homogeneous. There was no bilateral basal ganglia hypometabolism was there in F-DOPA. So this is very important. So this was the investigations which were there, which we had conducted.
Yes, as we can see, the patient and CT scan, they were done some 2.5 years back. The patient was already 2 years into the disease process. We don't know when the disease started. Maybe she came to us during the COVID era, at the beginning of the COVID. Maybe she was not able to ascertain her symptoms to begin with. But then the MRI was done, she had clear-cut atrophy of the bilateral parieto-temporal and parieto-occipital areas, which was, and there was subtle atrophy of even the posterior cingulate cortex. Then patient was lost in follow-up. She went for a DOPA PET and FDG PET. FDG PET showed hypometabolism in the posterior areas, visual association areas, posterior cingulate cortex, while DOPA PET was almost normal. Now, as Madam was asking, if you look at the literature, not many authors are working on this entity, but classically PCA, it has been divided into a biparietal, occipitotemporal, or even an occipital variant. But this can sometimes be misleading because when the disease progresses, the demarcation becomes blurry. So we may get a patient who has a feature of a ventral pathway dysfunction and sometimes features of dorsal pathway dysfunction. Again, the classical features like those of Balance and Gersman may not be present at the same time, and when the disease progresses, we may not be able to elicit those signs. And since this MRI was done 2.5 years back, at that time the patient didn't have cogwheeling. DOPA was normal. We are not sure whether uh, can it be still be a posterior cortical atrophy plus variant or level 2 diagnosis of posterior cortical atrophy. I'd like to have inputs from respected sir, Dr. Fahim.
No,
I think,
Yeah.
Atanu, sir.
yes, you can go. Carry on.
Yeah, please go ahead, sir. No, I just to agree with Ashwini, yeah, it could be one of the variants of PCA along with the plus symptoms which he already mentioned. So, yeah, nothing more to add. Maybe Atanu, sir, and Dr. Urushi, if they have any comments on this.
FDG8 was done this time, and the DOPA scan you have done long back or done just when the patient developed these motor features. After that, the DOPA
It was
scan.
done almost, sir, it was done almost 2.5 years back.
So we don't know exactly what is the DOPA scan when the patient developed the motor feature. And see, the most common cause of CVS is, of course, the corticobasal degeneration. That is, we see in the tauopathies. But one of the presentation of Alzheimer's disease is also the CBS, corticobasal syndrome, where we may not get the dopamine DOPA scan positive. As we are seeing that there is some hypometabolism in the areas of the posterior parietal cortex, and there is some asymmetry as well. So it could be don't have the amyloid scan or the tau scan. So we cannot say specifically that this is Alzheimer's, but this could be a variant of the Alzheimer's where there is features of cortical atrophy, but also the symptoms which are developing now. Patient also has features of cortical syndrome. As the focal Alzheimer's disease, we do see patients of cortical syndrome reported in the literature. Also, we see patients of posterior cortical atrophy in majority of the cases, and the pathology is Alzheimer's. But the overlap between the posterior cortical atrophy and the CS in Alzheimer's disease, I do not have any idea because we do not get to see the amyloid scan in these patients because it's not available in our country. But it could also be the corticobasal degeneration, form of dementia, lobar degeneration subgroup, which has developed initially as a posterior cortical atrophy and now developing the corticobasal like features.
Just to add for the interest of the audience, basically, it could be a clinical presentation of AD, and if we find pathology, it could be AD. Because CBD can have both pathology. They can have AD pathology, they can have tau pathology as well. So this patient could be a presentation with the pathology, but obviously we don't have scans, so we can't be really sure about.
Is there a difference in the rate of progression between the two for a differential? Say it's an Alzheimer variant versus a CB.
Yes, of course, the tauopathy progresses rapidly, but of course, this atypical variety of Alzheimer's disease, they do also progress fast. And the age of presentation in both the cases are in the fifth decade or so, or sixth decade. So early age of onset, rapid progression is the real indications of atypical variety of Alzheimer's as well. How fast they progress, whether the tauopathy progresses very rapidly or as compared to this atypical variety of Alzheimer's, difficult to say. It is there is no because the limited experience of this rare form of the Alzheimer's disease.
Thank you, sir. Thank you, ma'am. Thank you, Fahim. So, Anirudh, can you continue? Can you?
Yeah.
Yeah, you can give a brief review if you have. You have any literature review?
Do you have any review of literature?
Yeah,
If
yeah.
you could.
So, sir, just reviewing the literature as what I got was, so PCA was generally coined by D. Frank Benson, and it is a neurodegenerative syndrome dominated by mostly visuospatial, visuoperceptual, numeracy, and literacy abilities. And we can see pathological atrophy primarily in the visual cortex and the dorsal occipitotemporal parietal and occipitotemporal visual streams. Patients typically presents with vague and even bizarre visual symptoms, and onset is pretty earlier than amnestic variety. The PCA typically presents in the mid 50s or early 60s with a variety of unusual visual perceptual symptoms, such as diminished ability to interpret, locate, or reach for objects under visual guidance, which our patient had. Deficits in numeracy, literacy, praxis is very apparent. However, episodic memory is spared and insight is preserved. That is very important. Next, the forms of PCA include three parts. That is the biparietal form, occipitotemporal form, and the occipital form. Biparietal form is the Ware pathway. The occipitotemporal form is the Watt pathway, and the last is the occipital form. We have a criteria for posterior cortical atrophy, which was proposed by Crutch and colleagues. And we can see that we have already discussed all the clinical, which is that is the patient is having the insidious onset, gradual progression, prominent early symptoms of visual and posterior cognitive functions, and cognitive features were all there. But the relative thing which we have to see in for this is non-posterior cognitive features, that is relatively spared antegrade memory functions, relatively spared speech and non-visual language functions, relatively spared executive functions, and relatively spared behavior and abnormal behavioral. The neuroimaging suggests that it is predominantly hypometabolism in occipitoparietal and occipitotemporal regions. We have categorized for PCA, we have categorized for the updated criteria as into three parts: level 1, level 2, and level 3. Level 1 describes the core clinical, cognitive, and neuroimaging features and exclusions, that is the clinico-radicological syndrome. Level 2 distinguishes between a pure PCA versus PCA plus. Level 3 classifies patients with PCA attributable to specific underlying diseases like PCA due to AD, PCA due to Lewy body, PCA due to cortical basal degeneration, PCA due to prions disease, based on the availability of the biomarkers that can define the underlying pathology. Schematic diagram, which is telling us how to approach a patient of PCA.
Okay,
So
we
this
can
is
skip
the
this.
neurodegenerative process. We just would make out. And the criteria which was given for PCA plus and for as far as corticobasal degeneration syndrome was concerned was Armstrong criteria, and we have seen that there are three parts for that patient should have limb rigidity or akinesia, limb dystonia, and limb myoclonus. Plus two, patient should have orobuccal or limb apraxia, cortical sensory deficits, or alien limb phenomena. So this is the criteria for the cortical basal syndrome. As far as PCA with cortical basal syndrome, total in conjunction to be considered is approximately 1 to 2%. 18 to 20%. Whereas corticobasal syndrome presenting with visual symptoms are very rare. It is about approximately 1 to 2% only. So thank you.
Thank you, Dr. Anirudh. So we have planned this patient for another set of investigations. Maybe we'll go for brain imaging. Patient is yet to show us on follow-up. Dr. Fahim, any comments from your side?
Yeah, you want to briefly say something about management of these patients, because somebody has asked a question in Q&A. How do we manage and what do we do in such cases?
So, yeah, there are. Yeah.
So you continue.
Ashwini, go ahead. Yeah.
Yeah, I'm not able to hear you. Regarding management,
Yeah. Management.
is there any treatment available or in pipeline for PCA variant? Uh, we are not sure whether lecanemab has any differences between the conventional AD variant or the PCA variant. Or other than pharmacological therapy, there are certain cognitive stimulation therapies. I think Sandeep is not here, and they have done their work on cognitive stimulation therapies, whether cognitive stimulation and visuospatial stimulation or visual field stimulation like visual exploration training, they have any benefit in these patients. We have not much experience with these things in degenerative dementias, although we use them in other settings like reversible and vascular causes, or things like sustained attention training, then feedback training like the mirror therapy or virtual reality training. Uh, Other than that, pharmacological therapy, we don't have any indigenous data on. Over to you, Dr. Fahim.
Atanu sir, you are muted.
So, rightly said, Dr. The newer and monoclonal antibodies and this particular lecanemab has not been tested in patients with atypical AD. Those patients were recruited in the trial were the typical AD. So it is theoretically said this atypical ADs are the pure ADs who have amyloid and the tau in their brain, and this tau pathology exactly corroborates with the clinical finding. But for AD, there might be additionally other pathologies as well, like investor, memory loss, hippocampal atrophy, but there might be additional pathology of Lewy bodies, or there might be purely non-amyloid pathology like TD neuropathy. So we need to see future probably these atypicalities will also be included in the drug trial of newer anti-Alzheimer's drugs trial. As of now, we don't have anything to offer for these patients, and pharmacologically we have non-pharmacological therapies as well as said, rehabilitation, particularly cognitive stimulation therapy or other type of behavioral therapies are the only hope for these patients. They need to be managed and the family members need to be trained how to make them at least live a better life.
So I just want to add from the non-pharmacological part that yes, there are two components. One is when you're looking at the deficit itself and you're working towards it, like you talked about visual perceptual retraining and kind of exercises that are there. There is some evidence, but I think also when the person has such a level of progression that has happened for her, the goals would be more about, her functional daily activity, how to maintain that independence as far as possible, the counseling for the family, and a lot of environmental modifications based, so that she can navigate her way around with, it's more looking at a person with sensory impairments, so to say. So if you look at a near blind person or a near person with all those difficulties, how do you train them and how do you modify the environment so that they can still navigate their way and remain independent? So that their quality of life and that feeling of still being able to participate in life becomes very important. So this kind of thing is very individualistic. So when we work in rehab, we have the profile and we go into case by case, their background, the kind of support system, their home environment, what exactly they are facing in their daily function, with the goal of trying to modify all that so they remain independent as far as possible.
Fine. We have probably come to the end of the now. So, on behalf of the cognitive behavioral subsection, myself and Dr. Fahim extend our sincere thanks to Dr. Urvashi Shah for our excellent lecture, which probably have been benefited for all the neurologists and particularly those who are pursuing their postdoctoral courses now, and also for the new neurologists like us. And in future, we'll be glad to have her again for this cognitive neurology subsection course. I also thank Dr. Simi and also the Anirudh, Dr. Anirudh, who has presented an excellent case, a very interesting one, and also a very well worked up, I would say. So, and I also thank all our attendees who spared their time in the Sundays and attended in this program virtually, and also put their questions to help us make the program very lively. And I also thank the digital team of the Indian Academy of Neurology, particularly Dr. Asmita and Dr. Mansi, for giving us this platform, and also the thanks to our secretary, Dr. Meenakshi Sundaram, and President Dr. Devasis Chaudhary for giving us this opportunity to holding these webinars periodically. And with this, I hand over to Dr. Fahim. Please conclude.
Yeah, thanks, Atanu sir. Same, I would also like to extend my gratitude to all the speakers and especially Dr. Urvashi Shah for making us walk through this clinical talk, and more importantly, highlighting the essence of using these culturally relevant and appropriately adapted tools with the normative data in our Indian context. And this is important not only for an early diagnosis, but also for a very accurate diagnosis, so that we don't misdiagnose them, underdiagnose them, or overdiagnose them in our diverse context, and refrain from initiating cocktail of medications in a very initial stage. And thanks Dr. Ashwini and Dr. Anirudh for discussing a very interesting case. Again, that highlights what Dr. Urvashi said, hypothesis-driven testing, especially as we need to check the dorsal stream and the ventral stream here. We don't check usually, and which becomes very important. And I hope this was a great learning for all of us, especially for me. And thank you everyone for joining. And thanks to the IN team, Dr. Mansi and Nasmita, for all the technical help. And I think with this, we can conclude our today's webinar. And we look forward to everyone's participation in the future webinars to come. Thanks everyone, and have a great day. And thank you. You're muted, Dr. Urvashi. You're muted, Dr. Urvashi.
I just want to say thank you very, very much, especially Dr. Fahim for, really pursuing me and convincing me to do this. Thank you for this opportunity and wonderful case, and Dr. Biswas for the great comments. It was a huge learning for me. So thank you very much for including me. Thank you. Thank you.
Thanks.
Thanks,
Thank you, everyone.
Thanks.